Okay, assalamu alaikum everyone. I think that there have been a lot of conflict so far between cardiology and cardiac surgery. So to resolve this conflict, my presentation is heart team approach. So I think that cardiac surgery and cardiology definitely should work together, and my presentation is definitely on this topic. So let us begin with a clinical case scenario. A 70-year-old male, diabetic and hypertensive, and ejection fraction of 45% with class 3 symptomatic angina. On coronary angiography, LAD was 80% occluded, proximal lesion, circumflex was 90%, and RCA was 70%. Syntax score is quite high, 32. So, what is the best treatment option for this patient? So, in this case, I think the surgeons will say that this patient needs surgery, and cardiologists will say that no, we can fix this lesion with angioplasty. So, the heart team approach or heart team discussion can resolve all these issues, and there is not a matter of conflict. It's a matter of, the best treatment option for the patients, the best treatment option for the patient, whether he go for surgery or for angioplasty, and the long-term survival and long-term benefits. So I will cover concept and rationale of the heart team, evidence and guidance support, team composition and workflow, clinical applications, challenges, future directions. So the concept of a heart team is, it is a multidisciplinary model which integrates cardiology, cardiac surgery, cardiac imaging, and nursing as well. It focused on patient-centered, evidence-guided decisions, and it promotes transparency and shared responsibility. The rationale for a multidisciplinary approach is, there is a very increasing complexity of cardiovascular diseases, so there are multiple treatment modalities available. So the heart team approach reduces specialty-driven bias, and it also enhances outcomes and patient satisfaction as well. There are a lot of clinical evidences, as the Syntax trial, or the most focused trial, validated heart team approach, heart team concept for left main and multivalvular disease. Partner as well in the aortic valve, for whether TAVR or SAVR is feasible for the patient. Excel trials as well, certain guidelines, European Heart Association guideline, American Heart Association endorsed heart team for complex coronary artery disease and aortic valve disease, or mitral valve as well. So the team composition is very important. I think we knew that the interventional cardiologists and cardiac surgeon are the main pillars of a heart team, but an imaging specialist, cardiac anesthesiologist, heart failure specialist, nurse coordinator are also a part of heart team. And the last one, the patient and the family input is very important. As Dr. Farhan said, that many patients and the family do not opt for cardiac surgery because of its high risk, and the patient and the counseling as well, the lack of counseling, proper counseling. ये कहते हैं कि आपका सीना खुलेगा, आमतौर पे ये वर्ड यूज़ किया जाता है कार्डियोलॉजिस्ट की तरफ से भी, तो जो पेशेंट्स हैं वो वैसे ही जो है वो बैकफुट पे हो जाते हैं कि भाई PCI कर दें. So PCI is the short-term option, definitely, but for the long-term option, definitely patient and family, the proper counseling, proper informed consent from the patient and the family is very important. So how the heart team approach can work? Proper case referrals and data aggregation, and review of imaging and risk scoring, and definitely consensus recommendation, and at last documentation and follow-ups. Clinical applications are definitely in aortic valve stenosis, aortic valve disease. Our technique, which is known as TAVR, is gaining popularity so far. So the decisions of whether to go for TAVR or surgical aortic valve replacement, it requires a proper heart team guidance, proper heart team approach to decide. Complex PCI versus cabbage, another clinical application of the heart team approach is. So we evaluate the syntax score and comorbidities. Like in the previous case, just which we saw, 87-year-old male patient, 35% EF. So definitely, there are very high risk score for that patient going for cabbage. So this is a joint decision making for left main or 3 vessel disease, and it aligns treatment with patient goals and long-term outcomes. So how can we implement it? We should schedule regular multidisciplinary team meetings, daily, monthly no, नहीं हो सकती, but weekly at least. We should plan. We should schedule it. Use standardized documentation. We should document every meeting for every patient, and we should define leadership roles and communication pathways as well. Certainly, certain challenges and barriers are there. Definitely, scheduling and time constraints are there. It is quite difficult to schedule a heart team meeting every day or with every patient. There are certain hierarchical dynamics as well, limited resources, and definitely institution protocols are there. But every institution should use heart team approach model in their institutes. So the future directions are definitely AI is a future of everything, in every field. So AI-assisted risk prediction models should be there. Digital heart team platform should be there, and expanded use in heart failure, congenital and structural interventions. To summarize, the heart team approach is central to modern cardiovascular care, enhances safety, objectivity, and outcomes, requires collaboration, communication, and institutional support. Thank you so much. Any more discussion regarding the heart team or comments from our seniors?
Thank you. I think this was a first where people would mention even a heart team. I think it is absolutely mandatory that even in a small private hospital where a cardiac surgery is going on, I think there has to be a heart team discussion. I mean, it can be informal. The cardiologist can call the surgeon in the cath lab and show him the, show him the images, and then they can decide what they want to do. Personally speaking, I mean, I work at National Medical Center, and all the cardiologists, if they have this, if it's a straightforward case, then I say you just go ahead and do it, But if they have a problem, they always come to me, which is very good. The second thing is that in the report, the cardiologist will, and in the end, in the remarks or the treatment, they will say cabbage, stroke, multivessel PCI. Now that I think is I don't know about that, because you see, if you've written stroke multiple PCI, that means the patient will always opt for it, because you've said, there is an option that, so that stroke should, I tell the cardiologist, look, if you want to do a PCI, just do it. I don't even know about it. So there will be no controversy. You can do it, go ahead and do it if you want to do a multiple PCI. But don't write this stroke. If you feel the patient needs cabbage, then write cabbage. If you think the patient needs multiple PCI, then do it. Don't write it, because once you write it, the game is finished.
Yes, sir. Actually, a new thing is I saw in many reports, that is multi-vessel PCI or heart team discussion. That's it. No option for cabbage. multi-vessel PCI, which they have decided, or heart team discussion. So this is, I think, it should be changed, and it is definitely for patient safety and patient long-term survival risk. Thank you so much.
Farhan, can I make a comment? Very nice presentation by you.
Thank you.
I think the idea behind a pre-op counseling is to do with risk identification.
Yes.
Once you've discovered the risk, then the next step is risk mitigation. If you can mitigate that risk and bring the patient down into a good group in which you can operate with low risk, then that's the way to go. So I think you mentioned about the AI-generated risk identification. So if these go hand in hand, and we all know that if you have a lot of comorbidities, then CABG becomes a second option. If you have a lot of issues with the complexity of the disease, then PCI becomes a bad option. So we look at all of that, put it into the equation, and like Dr. Akhtar said, a lot of times that discussion takes place in the cath lab. And it's basically cardiologist, cardiac surgeon, and I think an important part of that team that you talked about is the non-interventional cardiologist.
Yes, yes.
I think because they have no conflict of interest, they become
Yes.
the most important person to give their opinion. Thank you.
Thank you so much.